Hello, everybody. This is Tony Ferranti from the New York State chapter. We'll begin in about another minute, but I just wanted to make sure that you can see the screen. And then we have all of our presenters will be here. So I'm pleased to be able to work this with our New Jersey chapter. We got a little body of water that separates both New York and New Jersey, that little river that in between. But a lot of people are very closely associated with both the New York and New Jersey hospitals. So we're very pleased to be able to do this as a joint collaborative event. We're all experiencing what's going on with COVID-19 right now and all the different rules and regulations that are cropping up. And today we're talking about the new future. How do we take care of, the temperature checking? How do we deal with the social distancing? How do we protect not only the employees of the hospital, but how do we also protect the patients that are walking through? So I'm very pleased to announce today the Rupa Shah, who is on the advisory board, will be leading a group of very knowledgeable individuals today, and will be able to go through a presentation that'll talk about how, with the relationship with COVID-19, that we're now able to help reduce cost and at the same time be able to protect everybody. So Rupa, it's all yours. Please take it away.
Thank you, Anthony. Hello, everybody. As Anthony mentioned, I'm Rupa Shah on the advisory board of Athena Security. I am going to introduce you to the speakers and the great institutions they represent today. Memorial Hermann Health System is the largest not-for-profit health system in Southeast Texas and has been around for over 112 years. John Calhoun is representing Memorial Hermann Health System. He is a Lean Six Sigma Master Black Belt in the Memorial Hermann Texas Medical Center Transformation Hub. John has led an extremely interesting and fascinating life, and I was very impressed with some of the stuff I read, and I'm sure some of you guys will take the time to read that. But John, in his current role at Memorial Hermann and throughout his career, has continued to focus on understanding what it takes to manage change effectively. He currently leads the scanner adoption technology within MHHS and will discuss the new normal, the challenges, piloting scanners, deployment approach, and future plans. McGovern Medical School is the graduate medical school associated with the University of Texas Health Science Center at Houston, UT Health. It is the 7th largest medical school, and representing them is Dr. Michael Chang. Dr. Chang is an assistant professor of pediatrics, specializing in pediatric infectious diseases. Dr. Chang also serves as a core member of the Medical Futures Lab at Rice University, which is dedicated to the study of the intersection of medicine and technology. Dr. Chang has studied the effectiveness of temperature screening and the variability in performance of thermometer types, and will be sharing his observations with us. Athena Security is headquartered in Austin, Texas, and our mission is to make the world a safer place, period. Athena in 2018 had launched a drone and concealed weapon detection platform, and earlier this year evolved to detect elevated temperature in people with a real-time alert system. Chris Ciabarra is co-founder and CTO of Athena Security. Prior to Athena Security, this is not his first rodeo, as we say. He was the co-founder and CTO of Revell Systems and was behind Revell's award-winning point-of-sale system made for the Apple iPad. Prior to that, Chris had founded Network Intercept, a security software company based out of California. Chris is also an anti-hacking expert and has provided internet security advice around the world, including the Department of Homeland Security. Chris will discuss various compliance requirements for the scanner technology. He will walk us through the components of a scanner, what you should be looking for, and talk about artificial intelligence in the computer vision space and how it is evolving today. Now I'll hand it over to John Calhoun.
And John, I'm just going to make sure you're off mute.
Oh, I hit it earlier and then I guess I turned it back on. So hopefully you guys can hear me okay. As Rupa said, I'm a Six Sigma Master Black Belt here at the Medical Center. I specifically focus, as she mentioned, on innovations that we bring to the Medical Center here. And like probably a lot of hospitals, most hospitals across the nation, when COVID-19 hit, we began to ask ourselves questions about how are we going to protect and screen not only our employees, but patients as they entered the facility. And so as we looked at it much closer, we initially looked at kind of two strategies. One was a passive strategy, where essentially we have our healthcare workers, self-monitoring, letting us know ahead of time whether they actually were experiencing any new COVID-19 symptoms. The second one was more of an active strategy. We tended to sway away from the passive strategy because we knew we also had to think about patients and visitors who were, again, we didn't necessarily have significant contact with before they reached the hospital. So we decided to really focus more on an active strategy. And in this strategy, of course, it means that when the healthcare workers or patients or visitors enter our facility, we wanted to have something in the physical area that we could actually screen them with. And so we started thinking about temperature screening at a minimum. So I'm sure that the folks online are familiar with the signs and symptoms of COVID. One of the key ones, obviously, is a fever. And so, we initially started this with handheld devices, and I'll talk a little bit about that more in just a second. But thinking about the devices, we also had to consider the physical area that we were going to use to actually do these evaluations. And then we wanted to make sure that we had enough time before, specifically our clinical staff, that we had time to do the screening such that they could actually make it to their shifts on time. So go to the next slide. Can you guys still hear me? Okay. So again, so we actually then began to look for institutions or entities that could actually help us with screening both employees and patients when they came through the system. Eventually, we landed upon Athena, and Greg Harrelson, who's the CEO here, worked with us. And I'm skipping ahead a little bit, but once we got the Athena system implemented, Greg was around. He kind of witnessed what was going on. And as you can see on this chart, and he'll talk about it a little later as well in the video that you'll see, that it really has changed the flow and has benefited the hospital here in terms of our ability to effectively screen people entering the facility, but also in terms of our ability to maintain social distance. So that the picture that you see there on the bottom right is actually one of the setups that we have within the TMC hospital. And actually, if I scrolled over to the right a little bit, you'd see that there's a second system. So we actually have a dual entry Athena system here. And that's because during the handover period, probably around 6 o'clock in the morning when the nursing shift change occurs, we probably have about 2,000 people that come through this entrance in the span of about an hour. And we have two such locations. So it really did help us kind of maintain the flow. So you can go to the next slide. Now, to talk a little bit about some of the challenges that we faced, again, when we think about it, we're going to end up screening about 2,000 people in one entrance when they come through. When we initially started it, if you look down again to the bottom right picture, you're going to see a thermometer there. We didn't actually start with the infrared handhelds. We started with the Exergen 5000s and 2000s, which are the ones you see kind of in that center picture. And those are contact thermometers. So for locations where we had about 2,000 individuals coming through, at given points during that handover, we had about we probably had about 10 to 15 individuals that were allocated to that location, each of those individuals with one of those in their hand. Now, the interesting thing about the picture is you see the little wipes there, because these are contact. Again, in between each use, we essentially had the screener obviously wipe the head off with the alcohol swab, and in some cases we actually did it twice. So what you see then on the left-hand side there is it took a significant number of people to do this, specifically during the screening handover. The time for screening was a little bit longer than we wanted. It ended up taking probably 15 to 20 seconds to clean the thing between uses. And of course that kind of contributed to social distancing issues. So having that many people come through at one time, it's really hard to have them maintain their distance unless we're able to move them fairly quickly, which we weren't able to do. And then the process was material resource intensive. So not only did we have wipes, we had batteries, we had masks, we had to hand out the whole bit. So it became pretty resource intensive. We initially started with the Exergens because based on the research that we've done, they were the most reliable and accurate handhelds. But again, they required physical contact. Eventually, we decided we needed to do something different. And so we went to infrareds at some point. But one of the things that we recognized with the handhelds was that the interaction between the operator and the thermometer was pretty significant. So we would have patients, we would have specifically employees that would come through one day, and after maybe a week or so, they would make comments to me that every day their temperature was significantly varied based on what they really expected. And that was the difference between, again, use of the contact handheld and the many operators that we were using. And they all had slightly different techniques. So as we initially started this, then we figured we probably needed to go and do some assessment of our ability to maintain a good operational control. And so we enlisted the time of Dr. Chang to do some assessments for us. So I'm going to turn it over to him just briefly to talk a little bit about what he did to help support it.
Great. Thanks, John. Hopefully you all can hear me now. So from a provider standpoint and from kind of a hospital epidemiology standpoint, our big concern was the Exergen thermometers, the 5000 and 2000 models, those are kind of widely accepted as performing reliably enough for temperature taking for a clinical setting. And so if we're switching to a new system using an infrared thermal scanner, the question for me, again, being involved with hospital epidemiology, infection prevention, and infectious diseases is, does the thermal scanner perform similarly to the kind of standard that we already are using? And so, there are some contextual issues when considering temperature screening to begin with, which is, there are publications that do discuss the effectiveness of temperature screening in the first place, and it's kind of mixed on how effective temperature screening can be to detect active disease, but there are some benefits to the temperature screening. And so the CDC has gone ahead and recommended temperature screening at hospital entrances. So within the context of the ongoing discussion of effectiveness of temperature screening, but also within the kind of recommendations of the CDC, we did not really set out to answer whether temperature screening was going to be effective in detecting active COVID infection, but more the purpose of this project was to look at the variability and performance of the thermal scanner. So given all that, the question, we really tried to answer with this little small study was looking at whether the temperature reported by the thermal system is comparable to the system that we're already using, which at the time was the Exergen 5000 and 2000 thermometers. Next slide, please. So when looking at the Exergen thermometers for the 5000 and the 2000, the manufacturer claims a plus minus 0.1 degree precision for the thermometer. And so we enlisted the help of one of our statisticians, Dr. Cynthia Bell, to kind of create a number needed to test, essentially, to determine whether the thermometers were all performing similarly. So we kind of put in a little buffer zone, and we assumed that the actual standard deviation for the thermometer performance was 0.3 degrees Celsius. kind of to give us a broader performance envelope. Yeah, go ahead and advance. And what we decided is, from a practical perspective, that if we could detect a 0.2 degrees Celsius difference between the Athena camera systems versus the thermometers, with an assumption of a 0.3 degree variability between all the systems, you can see that we would need 26 measurements to detect that 0.2 degrees Celsius difference. And we figured, again, from a kind of a clinical perspective of detecting fever, 0.2 degree Celsius performance would be good. So over 2 sessions where we performed at the same location, one of the sessions was in one location and then the other session was in another location, but all the temperature measurements were within the 2 sessions. We took overall 312 measurements by the Exergen 5000s and 2000s, and then we did 26 measurements by the Athena camera. So we did 13 Athena camera measurements in the first session and then 13 in the second session. The thermometers, what we found was that there was a lot of variability, as John mentioned, between users. So we simplified to a single user, and so we had the same person doing all the thermometer measurements, and then the person having the temperature measured was me. So I had my forehead scanned 312 times to get a temperature measurement. And so what we found, next slide please, was that when you look at the performance of the different thermometers, essentially they perform the same. So the TAT 5000 model was reported by our temperature screeners to be easier to use. And so the numbers actually were a little bit more consistent with that model. The 2000 was reported to be harder to use, and you could see a little bit more variability. And so we ultimately compared the Athena system with the 5000 models, and you could see that they're within essentially the same range, and there is no significant difference between those 2 particular models. And so from my perspective, again, from a clinical kind of performance standpoint, where we're concerned about detecting fever, again, within the context of all the ongoing discussion of effectiveness of temperature screening, I felt, and discussing with our statistician and some other infection preventionists within the hospital, that the performance of the thermal scanner would be comparable to the handheld Exergen 5000 models that we're using at the time. And so because of the other advantages like throughput, the ability to social distance, the fact that you didn't have to actually contact the person having their temperature measured, reducing, you essentially have no cleaning time with the Athena scanner, whereas with the thermometers, you had to wait 20 seconds for the alcohol to dry, et cetera, et cetera. We felt there were enough operational advantages, at least from, again, a clinical perspective, that the Athena system would be comparable in performance to our current model. So with that, I'll turn that back over to John and let him summarize.
Yeah, so just in summary then, you can think about where we started. We started with the handhelds. I can tell you very clearly that it was very resource intensive. So we had a lot of people, as I mentioned, 10 to 15 people at one location, and we have 5 entry locations. So that wasn't going to really last for very long. And so as we made that progression, we were also paying attention to the physical distance between people when they were entering our hospitals. And we found it very, very difficult, specifically during the handover time, to both get people through in time to make their shifts and maintain a minimum of 6 feet social distance between people. We just couldn't do it. So for us, once we went and we made the change to Athena's, it's very quick. I mean, folks can just keep walking as they pass the scanner. I mean, for some time we actually had people stopping because we wanted to make sure the equipment worked as it was advertised, and it does. But once we really got comfortable with it, it became a game changer for us. So we're able to get essentially 7,000 people through in a span of an hour in the hospital during shift changes. Definitely, it has done a much better job of helping us maintain social distances. So when people are moving, they're not as likely to bunch up, and so we've seen that. And we specifically like the fact that it's no contact, so the ability not to have to touch people. I know all of our employees and our visitors see that as a positive as well. And lastly, it significantly reduces not just the human resource, but the material resource load for hospital entry screening. I do want to make one other point, though, that Michael mentioned earlier. We, like most hospitals, started by calling this fever detection, and we had a specific limit, was 100.1 degrees Fahrenheit. And we've since switched to call it elevated temperature detection. And we essentially use a two-step process where we use the scanners and we set the temperature a little bit lower because the scanner, the infrared temps tend to be just slightly lower. And so we have a lower threshold. If it triggers 99 or so, then we can pull the person aside and typically then check them again with the Exergen 5000 thermometer. So that's worked well for us. You can go to my next slide. And so lastly, for me, just thinking about the investment in the scanners, we also wanted to make sure that we were investing something that we could use long term. And we particularly like the fact that the scanners that we've invested in can ultimately be used for things like foreign object detection. And we didn't do this initially, but all of our systems right now are standalone because we wanted to get something up and going very quickly. But we also know that we have the capability to go to an integrated or cloud-based system where we can interconnect the systems and perhaps do central monitoring. So it's been very helpful to us. I think that's really all I wanted to share. I'm going to turn it over to Chris for the next slides.
Hey everybody, this is Chris Ciabarra here with Athena Security. I'm going to go over the system a little bit and give you some references and how it works and what to look for when you're looking at a system like this. You want to make sure that it's NDAA compliant. This means that the actual system is not going to snoop on you or send information to people that shouldn't be receiving the information, basically. HIPAA compliance, obviously you're all aware of that. You want to make sure your system's HIPAA compliant. You don't want to be showing people's temperatures to other customers coming in the hospitals or your building. And then of course there's FDA compliance. You have to make sure that the equipment that you're using actually complies with the FDA guidelines and making sure that it's accurate enough. There's a lot of different types of cameras out there, and I'll show you a little bit later how to run some tests on these types of devices so you can actually see which ones are good, which ones are not good, and you can make your own decision on where you go with it. Some of the main things is it has to be 0.5 degrees Celsius or better in accuracy. It's got to be 0.2 degrees Celsius or better with drift. Next slide. Okay, so here's a demo of the system. Go ahead and start it. What you see right there is one of the actual scanning cameras that we sell. It's a thermal imager and a visual imager. Over here you have what's called HSRP device, heat source reference point, or black body as they call it. This tells the camera exactly what the temperature is, and it recorrects the camera every quarter of a second, so it makes sure the camera is always accurate. You have someone walk by, you'll see the person's temperature reading, and it'll put them at the bottom of the screen there. This is just the flow of people, so you can see how fast people can be walking in. On the left-hand side, you see the people being added to the console, and you can see the people walking in there on the right. So it's 6 feet apart, they should be, and they can just keep walking, they don't have to stop. Okay, so the next frame, what you're going to see here is the 3 different types of camera setups. Oops. Okay, so on the left here, you have the actual dual imaging camera with the black body unit HSRP device there. In the middle, you have an iPad. It's just a front-facing display if you want customers to be able to see it with the actual camera. And on the right, you have our single lens model, which is our new model coming out. It'll be just that lens with an iPad. It's a kiosk version. Okay, this is our alerting platform here. You can actually see an alert through a web browser, iPhone app, Android app, just an easy way to receive alerts. You can get this through the VMS, your security console, or access control systems. You can receive alerts. So you don't have to be there watching every single entranceway. You can have your main entrances covered with people, and the other entrances that have lower flow, you can be self-staffed. Okay, so with artificial, could we go back to the video real quick? Because we missed a bunch of the video there. Just fast forward it a little bit. little bit back. Okay, right there. Perfect. Thank you. Okay, so what you'll see here, after the people start walking by, you're going to see our back-end console. Our back-end console is where you receive the alerts. If you wish to see them, you can just easily just click on a actual alert, blows it up real big so you can see what's going on. You get the visual side and the thermal side in one. And any system that you choose should have an alerting console so you can keep records for compliance, for HIPAA compliance, and for your internal HR compliance. You need a record of these things because if someone says, I need to take a look at a later date, you need to have records of it. It tells you the location of where it happened. It tells you if it's a high temperature or low temperature on the alerts. You can filter the alerts, of course, and you need some kind of system to be able to handle this. A lot of systems you only see once and it's gone. The next day you don't see it anymore. Right now it's showing you third-party compliances. You can actually hook in VMS consoles into the platform so you can send your alerts to your VMS or security consoles. It has an enterprise management system. You can create users and then build those users so each user can see what they want to see. One camera or all cameras in your facility. Here's a test. You should be testing all of your types of cameras that you're going to choose. Doesn't matter who you go with, but you want to make sure that it works. Can you do multiple people at once? Yeah, you can, but the FDA mandates that you don't do multiple people at once. So you need to do one person at once. Go back to the video. So what you see here is you see a person taking off their glasses and putting it back on. What that means is if your camera that you're looking at cannot tell the difference, your inner eye is the hottest part of your body. So when you take off these glasses, that person's temperature changes 0.2, 0.3 degrees. And if the camera can see that, then you know you have a good enough camera. If it can't see it, then you should be looking at a different camera. That's the easiest test that I tell people about. We call it the ET test. The test you're seeing here is extreme temperature test. They're coming in from outside. On the left-hand side there, you see that they have high temperatures, right? They're coming in at 100 and some degrees. It takes them about 20 seconds to actually adjust coming in from outside temperatures. So you want to do a test like this to make sure, A, that your system's going to alert, and then B, that it can tell the difference within 20 seconds that that person's temperature came back to normal. This test we call the drift test. What you see here is two black body or two HSRP units. The bottom one is one of our competitors, won't name them, and the top one is us. You'll notice that when we tested the drift, it changed 0.4 degrees on our competitor. It changed 0.1 degrees on ours. So you got to run these tests because 0.4 degrees is not an FDA, does not follow the FDA guidelines. It needs to be 0.2 degrees or less. So when you're testing out other equipments, you can easily run this type of drift test where you just look at the temperature on the HSRP unit, the black body unit for 24-hour period, and you take notes for 24 hours, and then you see the maximum drift within that 24-hour period. You know, ours is 0.1. You don't really want to be above 0.1. FDA allows you to go 0.2, but 0.1 obviously is the best. If it goes above 0.2, you should be looking elsewhere, basically. Okay, that's it. Go ahead, next slide. Go ahead, next slide. Went over this already. Okay, yeah, next slide. Okay, so as far as artificial intelligence, where is it going? You know, it's been around for the last 20 years. Anything that you're going to be automating, you know, is artificial intelligence. And if you look at the future, you're going to see more and more jobs get automated. Tasks, if not entire jobs, are going to get replaced with AI. Right now, we're focused on, you know, computer vision and doing different types of things that we can automate. You know, elevated temperatures is what we're doing now. We were doing drawn weapons before, slip and falls, you name it. You know, we can automate it depending on your needs. And in the future, that's what you should be looking at, because you should if you can replace a job with a computer, why not? You know, have people do other things more important than what can be automated, basically. Next slide. Okay, here's a video of Memorial Hermann's CEO. Do we have audio on here? Well, hopefully everyone else can hear it. I cannot hear it.
Mark, we don't hear it. Could you go back to the beginning of the video and run it?
The coronavirus, and with more businesses reopening across our state, many places are quickly adapting to new health and safety measures.
I've lost sound again.
Mark, you want to try running that one more time?
But many places are quickly adapting to new health and safety measures.
One hospital is taking a big leap forward, scanning the temperatures of people coming in while maintaining social distancing.
Channel 2's Mario Diaz is live in the Texas Medical Center tonight with more on that story. Mario?
Chris, Lauren, we have heard so much about what the future is going to be like, but behind me at Memorial Hermann, they are bringing the future into the now. For a look at the future of building entrances, all one has to do is go to Memorial Hermann at the Med Center, because the future is there now.
Having these scanners has been a real game changer for us.
Temperature readers with social distancing taken into account, all done through a standalone system, captured in a matter of seconds.
We're screening about 6,000 to 7,000 people through our entrances every day.
Okay, so there you see. Okay, go ahead.
Okay. So we talked a lot about, why these scanners and the practicality and being able to move a lot of people very quickly. So it was the performance and quality and on all of that. One of the things that we should also, and I know it's at the back of or in the front of everyone's minds, is cost reduction. So we did a quick check on this total cost of ownership, and especially around labor costs. As John had mentioned earlier, at one entrance, they needed about 10 to 15 people at any one given time. And that was just one entrance. So we looked at 2 hospitals in the Mid-Atlantic that are currently using handhelds, and using them as an example, we looked at what that translates to for on a monthly basis, and that's around $875 to $1,140 per entrance. You can look at your own numbers and estimate what your costs are today, whether you have a 24/7 operation, a 12/7 operation, or a 12/5 operation. What we have learned and understood from our clients, and this is not just in the health industry, but even in other industries, because we have seen this at airports, commercial spaces, manufacturing plants, the labor cost can be reduced from 50 to 75% if you're going to use handhelds versus scanners in the long term. So just wanted to leave you with this at the end. Go ahead, Mark, the last slide. And if anybody has any further questions, please feel free to contact our representative, Sam. I'll hand it back to you, Tony.
Thank you, Rupa. And thank you for everybody who was able to join. This session will be recorded, and it will be available both on our website as soon as we can get it up, and as well as the New York State chapter has created a YouTube. So we'll publish that out to all of our members, and hopefully we'll be able to have you be able to review at your leisure for those that couldn't make today's call. I noticed that the Q&A session was a couple of chats out there. Let's see if we have anybody that has anything. Just some that they couldn't hear. And then it said, okay, now it's off mute. Okay, so everything was good there. Thank you again, everybody.
Okay.
And I want to thank also Jim Hennessy from the New Jersey chapter for also helping to push this out to his members. And we'll be looking forward to the future when we can do other events very similar to this. Rupa and staff, thank you for your time. I think you did a great job today.
Thank you, Tony.
Thank you for having us.
Thank you for having us.
Yeah.
Thanks, everybody.
Everybody, thank you again, and have a great day, everyone.